$4.5 trillion of US healthcare spend, and the American Diabetes Association said $1 out of every 7 are spent on diabetes.
And 83% maintain control for 2 years without hospitalizations.
End-of-life care has become incredibly expensive. We have the right technology, we have the right medicine, we have all the right ideas, but it's not working. We're not a digital health company. We're a medical practice. My goal is to help 1 billion people have a better life.
We can start at the systems level.
We're really careful about how we apply technology, right? So when we're applying technology to anything that's clinical or clinically tangential, we have a much higher threshold for safety and security. A lot of people think that technology can take the place of that human interaction. And the answer is you've got to meet the patient where they are with the technology. At the end of the day, we don't just want to fix the clinical outcomes. We also want to fix the economic incentives internally. If the government came to us and said, we have a Medicaid population, you have to do this within the bounds of the economics of Medicaid. Could you do that? The answer is yes, we can.
Hey there. So let's starting over. Chronic disease is the biggest operational and financial drag on the US healthcare system. Diabetes alone costs over $327 billion annually, and most healthcare systems fail to move the needle, especially in underserved and rural communities. But my guest today has built a system that actually works. At Persina Health, John Oberg led a clinical and behavioral protocol that improved A1C from 9.6% to 6.4 for 49 out of 50 patients within 12 weeks. And 83% maintained control for 2 years without hospitalizations. The results weren't achieved with expensive tech or ideal conditions. These patients lived in low-income, resource-limited environments where most digital health and chronic care models break. And John has spent over 30 years studying behavior or human behavior, organization, performance, system design, and leadership. He's led teams of 1,000 people, advised billion-dollar organizations, built health sharing networks, chaired boards, and taught future leaders at USC. For the healthcare CIOs, CTOs, and startup founders listening, today's conversation is not just about theory. It's about system architecture, workflow design, behavioral mechanics, and the structural decision required to scale chronic disease management with predictable outcomes. John, welcome to the show.
Thanks for having me. I'm really excited to be here. And not to make matters more dire, but those numbers you gave might tell a rosier story than what's actually happening. $4.5 trillion of US healthcare spend, and the American Diabetes Association said $1 out of every 7 are spent on diabetes or diabetes-related outcomes. And so the numbers you were giving are kind of older numbers that include some soft costs, but the real hard costs these days might be now north of $500 billion.
Wow, that's really putting things in perspective. Thank you for sharing that. So I guess we can start at the systems level. You said that healthcare and society at large has become transactional, disconnected, and structurally misaligned. From a system design perspective, what are the exact structural failures in today's chronic disease models that, from your perspective, prevent adherence, scale, or sustain outcomes?
I think there's a number of problems we have. One being that the administrative costs have far outpaced the growth of the cost of care over the last 30 years. And these are broadly known problems, right? Nothing that I'm the only expert in. There's a lot of people who know this space better than I do that show kind of the graph of the administrative expense far outpacing the growth of care expense. So that's a really big problem in terms of how we're administering care. And I think that, we are spending a lot of money in places that end of life care has become incredibly expensive, and that's not to say we don't want to try everything we can to help people live longer, healthier lives, but I think there is an honest conversation to be had around end of life care where we're not extending someone's healthy life, and so I think that's a place to look. And then metabolic disease, the place where we specialize, there's a lot of money being spent, and the solutions have we have the right technology, we have the right medicine, we have all the right ideas, but it's not working. And that's why we went back to 10 years ago, look and say, how can we fix this problem? And, you talked about the study we did quite some time ago. We're just about to release some data where we took 79 patients from an average A1C of 11 and dropped them into the low 7s over a 12-week period, and then got 30% of the people who were on insulin off of insulin at the 6-month mark. And so we think there's I've got one patient, I just got a story this week that they came into the practice on August 8th of this year, newly diagnosed type 2 diabetes, blood sugar in the 800s. I mean, just really sick, sent to the hospital. A1C on 724 was 11.8. So they showed up to our office about, what is that, 15 days later on the 8th. And on November 4th, so about 6 days ago, the repeat A1C was 5.6%, and insulin was discontinued for basal insulin. I mean,
Wow.
those are the kinds of results we're seeing with our new protocols.
Wow. So in terms of the current system, do you see, this being a misalignment of the operating model that is being followed, or do you see it more so like the workflow or the accountability or the feedback loop junction that you feel is just not aligned properly?
I would say that we found a gap in the system. I mean, primary care is primary care and needs to continue to be primary care. And primary care
Mhm.
physicians, I mean, an amazing job they have to do, and there's so much work that has to be done. And I think that we're starting to see that, we're underappreciating primary care in a lot of ways. And so I think there are steps being taken at the policy level to adjust for that, which is really, really good. I think, there's some gaps in the care model, though, where you have these really high acuity patients that require a different set of not just clinical protocols that we've utilized in our practice. We've also changed all of our administrative protocols to kind of really wring out the extra administrative cost that doesn't need to be inside of our clinic, so that we can make it not only a clinically effective model, but a financially effective model as well. But that really meant rethinking the entire business model, not just the clinical model for our practice.
Hmm. That's interesting that you speak about the clinical model for the practice. Have you made changes to the incentive structures as well internally to make it more about the outcome rather than the visits? Is that what you're trying to say?
I mean, no, clinically, we focus on a specific set of kind of medical and then behavioral health protocols that we use to get people healthy. And we're very focused on the clinical side with clinical results. So hemoglobin A1C being the easiest one. We talk about hypertension, obviously, it's blood pressure, CHF, like we look at cardiovascular disease, type 2 diabetes is our main focus. And then we think, some of our patients have come in with pulmonary disease that has the same methodology for treatment. But those clinical outcomes are super, super important. But we also have a whole set of business outcomes on the administrative side about keeping costs down for the patient, keeping costs down for the payer, for the system, right? Because at the end of the day, we don't just want to fix the clinical outcomes. We also want to fix the economic incentives internally. And so really what that means is wringing extra work out of the system. We do that by using automation and artificial intelligence, like anything we can do to make it lighter administrative lifting for our practice. We've done that. But that's a lot of work.
Yeah, I can totally understand. It's changing the current process and making sure that people understand or are connected to it. Especially when it comes to like automation. I cannot even imagine the kind of pushback that you would generally get. But let's kind of dive into the predictability aspect of it. Obviously, like this is not outlier behavior. You have 49 out of 50 patients that have gone through this. So I mean, the outcomes are extraordinary and rare. Let's just call it that. But to dissect the architecture a little bit, what are some of the non-negotiable structural elements of your protocol that you think made the behavior change happen and the glycemic control predictable and repeatable? Could you sort of speak to that?
Yeah, so the paper we're about to release talks about the first part in great detail, which we call START. So systemic therapeutic alignment and rapid titration. So what we do is we go in and look at all of the medical things that a patient is faced with for that patient in a hyper-personalized way. And then every medical condition gets a severity score. And then we take all the mental health conditions that may be playing a role, and we evaluate whether or not they're playing a role. And those also get a normalized severity score. And then we do the same thing with a number of non-clinical variables. So some of the social determinants of health, for example, or some of the health beliefs. And we take all those things, normalize severity, and then we actually look at the readiness for change of a patient and find out where the patient is ready to make changes. And then we start moving them through a behavior change process that generally starts with medicine first and making sure there's medical adherence, and then moving into exercise and diet and the things that really matter, but in a very, very radically incremental approach that's hyper personalized for the person. Because I think most physicians, broadly speaking, know you have to eat better and exercise. But if you move someone from a very poor diet and you tell them to improve their diet over the next 2 weeks, that's very hard for someone to get their arms wrapped around that. So with our providers, when someone's ready to make exercise changes, we talk about things in 10-minute increments, right? Like, how do you make those really small changes? With food, we give them meal plans that include not just the meal plan, but the recipe and the shopping plan, and then how they're going to cook it together, and the storage plan for leftovers and how they're going to eat those leftovers based on the size of the family, based on the type of cooking they both enjoy doing and are capable of, based on what things they actually have in their kitchen. And so hyper personalized planning makes it easier for us to help the patient make really, really small steps. So in one example, we helped the patient just change their coffee creamer. And that was the one change we were going to make for the next 2 or 3 days to see if that was going to work for them.
Wow. That's that is hyper personalized. That's
Right.
for sure. I think, yeah, I mean, the things that you touched upon from, kind of using behavior change as a system, almost that you kind of codified, with the practice. I think, I mean, first off, sort of using the identity-based behavior change, like, not relying on their willpower to actually make the change. And then you mentioned reward systems that are also built in, sort of that are triggered by action. So, and that's kind of structured on their daily workflows. And the fact that you're able to kind of remove the friction that I feel is the number one issue with most of these behavior systems that are kind of part of it. And then it's also co-regulated in terms of like the human connection that you mentioned. So kind of walk me through these two components. So let's call, so one is the digital tracking component, right? So there has to be a digital component that works with them, that reacts to their changes in environment and what they're kind of using as meal planning or activities and things like that. Then
Yeah.
there's a human driven, which you went very much in detail on, but I'm assuming there's an emotional coaching component or motivational breaks and things like that are part of it. So can you kind of walk me through the system a bit more in detail?
Yeah, I mean, I would say that in removing friction is a great way of talking about it, but I don't want to give you the impression we remove friction on day one. What we do is we try to identify the friction and remove it, and as often as we do it correctly, we miss. And so the key is not to not miss. The key is to miss and change quickly, right? So for example, if a plan's not working for someone, waiting 2 or 4 weeks to the next appointment is too long. Someone's too far off the rails after 2 weeks of missing. So if someone's off the rails in 24 or 48 hours, like, how do we get them back on the rails very quickly with a plan that actually works? And so now, to get a plan that actually works, you have to know what the patient is willing to do, but you also have to have an expert plan, right?
Hmm.
So like, if a patient were to say to me like, "Hey, I'm going to stop eating sugar, but I'm going to keep eating like you know, natural, synthetic sweeteners," like, that may not be the best long-term plan for that patient, right? So every patient needs a plan that's going to work. And when it doesn't work, we very quickly make a quick change to that plan. And that doesn't mean we see a patient for an appointment every 2 or 3 days. It might just be a quick check-in phone call,
Mm-hmm.
right? Where it's like, "Hey, this isn't working." It's like, "Hey, let's go to a backup plan. Let's make a smaller change. Let's change direction just a little bit." I'll give you a real example. We had one patient that was like, "I'm going to go walk a mile today." We're like, "Oh, hold on. How about you just walk to your mailbox?" And
Hmm.
they complained the next day. They're like, "My knee hurt on the way to the mailbox." We're like, "Wait a second. You didn't complain about knee pain yesterday."
Hmm.
Like, "Well, no, but I was walking in a straight line yesterday." We said, "Well, tell us what happened." It turned out they were turning left at their mailbox to turn back around. And we
Wow.
said, "Okay, well, tell me more." And they described the situation. We said, "Well, do you have a cane or a walking stick?" Like, "I have a trekking pole." It's like, "Great, grab a trekking pole. Here's how you plant it next to your foot when you turn back around to come home. Try that and call me." They texted back
Wow.
like, "Oh, it didn't hurt at all. I went to the mailbox twice."
Wow.
It's like, "Well,
That's
that's great. Now let's talk about getting to the corner."
right, right, right. That is super granular, overall. But so let's kind of speak more to the tech side a little bit. And I'm gonna
Yeah,
give you like both aspects, because I want to sort of play devil's advocate with my own question. But
sure.
let's say, you know, let's kind of talk through about what behavioral steps can and should be digitally tracked. And then on the flip side, I would want you to answer what are some of the, from a tech perspective, what is the role of tech where
Yeah.
CIOs kind of overestimate in terms of behavior and adherence?
Yeah, I think this is a great question. I think a lot of people think that technology can take the place of that human interaction. And the answer is you've got to meet the patient where they are with the technology. And, the internal debate we've had in our practice that's kind of most along these lines is around constant glucose monitoring, CGMs. And, there's a limited number of cases where CGMs clinically make a ton of sense, right? But there's a much bigger set of circumstances that make sense when you talk about behavior change. I'll use myself as an example. My A1C, I was diagnosed with type 2 diabetes at one point along the way. So ironic, right? And I very quickly controlled, and my A1C was then in the control. My last A1C was like 4.9, but I still have a CGM that I wear occasionally because it shows me what behavior is taking me the wrong direction or the right direction. And that level of data is helpful for my behavior more than it is clinically necessary medically. It's clinically necessary on the behavioral side, but not clinically necessary on the medical side, right? And so,
Hmm.
it's like, where is data helpful? There are people who want all the data in the world to support their behavior change and sustainability. They should have access to that data. There are some people where that data is overwhelming, and so they should take less data. And so as we built our patient portal with AI built into that patient portal, we're trying to teach the AI right now, like what data is appropriate for each patient, because it's going to be different for each patient. And by the way, it changes over time. Some patients want a little bit of data, then they want more data. Some people want lots of data, then they want less data. Some people want a little data all the time, but more data when things start to go the wrong direction. And so all those things need to be considered if you're going to help people have long-term sustainable success while you're lowering treatment burden. Because technology can just as easily lead to more treatment burden for a patient, which is not actually helpful in terms of dollars, in terms of time, but also in terms of emotional cost, things like anxiety.
Hmm.
So it's not a one size fits all world for technology.
So I guess, I mean, from what I can hear, you're saying that the dashboard that these patients are looking at, that also changes based on what their need is using AI on the back end. Is that
That's right.
the way it's structured? Wow,
That's
oh,
right.
that's impressive. So, as a technologist, I guess I'm kind of curious. How do you sort of how is that being embedded? Like, is like in terms of system architecture, could you just kind of walk me through that part?
Yeah, we have a partnership with Salesforce, which does an amazing job of keeping our data secure and making sure that we can plug in and unplug the different kind of AI models we need in the right places, the right times. And then it helps us to expose things in a very modular, flexible, and extensible way so that we can have that type of personalization. And they've been a great partner in helping us understand, how to use them as the platform. And then we have, some custom built technology on the app side, for example, where we can say, okay, we need to have a very, again, modular user interface that's very AI forward so that you can actually have the AI present the information the patient needs. And we're still early days in creating this. I mean, I think UI is going to change really radically over the next 18 months across all software platforms. I think you're going to see less keystroke. I think you're going to see more natural language interfaces with people. I think the way that we look at analytics and dashboards and reports, I think we're going to see some really different human behavior in the coming, months and years.
Gotcha, gotcha. Yeah, I mean, I can totally relate to some of the components that you're defining when it comes to like not keystrokes, but event-driven architecture that gets triggered by human or automated actions on the back end, right? And then you mentioned, the way you're looking at dashboards. To me, it sounds more like care pathway orchestrations, which are in the back end defined by the stage the patient is in, and that allows them to see what they actually need, and based on different stages, it changes for them. And
Yeah,
then
I would say maybe. I think that may be a little old way of looking at it because I think staging can be dangerous because that would indicate a linear model in some
Mhm.
cases. And I think in the future it's got to be more nuanced than that. And we do have a staged approach for us, right? But we're very clear that our stages are not linear stages. They can be circular. They can be two steps forward, one step back. They can be one step forward, two steps back. So I think staging is helpful from a definitions perspective and normalizing kind of clinical shorthand. But we
Mhm.
do a really explicit training work around our clinicians to make sure we identify where somebody is, and we almost reclassify that staging every interaction we have to make sure someone hasn't moved.
Hmm. Interesting. And it comes to when it comes to like having a single source of truth for behavior and clinical data, how do you merge them together?
Well, I think that's where Salesforce has some real genius for us, because with
Okay.
Data Cloud, they allow us to go and access data in so many different ways, and to do it cost effectively and to do it in a secure way. Like, we'd done 3 prototypes before we chose them as a partner. And when we started to look at what we had to do to scale from a cybersecurity perspective and from a HIPAA compliance perspective and a PCI compliance perspective, and it just became daunting. And so we went out and found a platform, and we evaluated lots of different platforms to do this. And so, we're not a technology company. We build a lot of our own technology. We do certainly a lot more than other medical practices do, but we're a medical practice. That's what we are first and foremost. And so it was good for us to have a partner who could really lean in with us. And we've been really excited about the partnership and how they treated us.
Interesting. And when it comes to like escalations, what are some of the data points that you think must trigger an automated human escalation in your data points?
Yeah, I mean, for us, we have administrative escalations, we have clinical escalations. Sometimes we just have behavioral escalations, watching how someone is or is not behaving. Those
Hmm.
are things that happen. I think about years ago, we had somebody who was in control for a long period of time, and their blood sugar spiked kind of out of the blue, and it was just a very kind of large anomaly. Nothing dangerous, but ended up on the phone with one of our providers. We said, "What's going on?" And they said, "Well, I'm in Miami visiting my in-laws, and I just ate half a pizza. Not normal behavior." It's like, "Are you good? Are you okay? You need to talk?" "No, I'm fine. I'll be okay by Monday." And so it gives us a chance to kind of intervene early in places where we see kind of a really kind of massive outlier too, which is great.
Interesting. That's and I think that's a great pivot to the next segment that I wanted to kind of dive into. So in terms of like KPIs, right? So most organization I feel like track too many KPIs and often the wrong ones. From your experience, what are, let's say, 3 metrics that actually predict long-term control and should be monitored daily?
Yeah, I mean, long-term control is sometimes is a hard won daily process, right? So I
Hmm.
think, the first thing that would be an indicator of long-term control is short-term control. Like, how is someone adhering to the plan, and how are they at simplifying their plan, right? And so for us, we look at, like, how many medicines can someone reasonably come off of over time. There are some people that aren't going to come off of some of the medicines they're on. That's just true. So that's going to be a harder long-term sustainability issue. And then you just look at what behaviors are behaviors that are going to be sustainable for them, right? So if someone is eating primarily processed foods today, getting them into kale salad 7 days a week is probably not a medium term goal for us, right? Like,
Right.
we just want to help them move in the right direction. So we look a lot at vectors, right? Like, what's the direction and what's the pace of change? And we're generally trying to get people to commit to less than what they're excited about, because they start to see all these great results and they want to go faster, faster, faster. We're like, hey, let's just, that's great. We can get there, but let's just one little step, one little step, one little step.
Interesting. So from what you're telling me, I think daily adherence rate is like a definite must to have. Like that's probably the biggest predictor of A1C that kind of shows up when you do your test. But meal compliance is another component which you're kind of tailoring using a very, very hard touch point. When we talk about the counseling or coaching, does it stay consistent throughout the process or does it taper off eventually when things are more regularized
No,
for the
definitely.
patients?
Yeah. As people gain habits, you want that coaching to taper off, because every time you have a coaching event with a patient, that creates treatment burden, right? So in the long term, you want treatment to tailor off, and then you just have monitoring, right? And you want monitoring to be lower and lower and lower burden over time, right? And then you just want to have monitoring that is, almost unnoticeable, right? So that you can then jump back in if you see somebody who's off track enough to warrant, jumping back in.
Interesting. One of the other things that I also mentioned at the start, which I want to kind of come back to because it's really important, Your model didn't just succeed in, sort of high-tech urban areas. It succeeded in rural and underserved communities where digital
Yeah,
health pilots usually fail.
that's right.
What specific design choices made your model scalable in lower resource environments?
Yeah, I think there's a couple things to note. Like, we're not a digital health company; we're a medical
Mhm.
practice, and so there is a digital health component to what we do. But if someone didn't have access to the internet, we can do everything we do by phone. As one example, right? It's harder to do, but we can do that. And so we specifically went in, looked at everything we wanted to get done. We said, okay, how do we do this in a low income, low access to care environment? And how do we rebuild the entire system around that so that if the government came to us and said, we have a Medicaid population, you have to do this within the bounds of the economics of Medicaid. Could you do that? The answer is yes, we can. And so that was one of my mandates in my research to get my doctorate. Like, I wrote myself that note, like, if this can't serve a Medicaid population, we haven't solved the real problem that I wanted to solve. Not to say there's not a real problem out there like that, but I wanted to solve a problem at the very least that could solve it for the Medicaid population. And now I'm getting asked questions by some of my advisors about how do we take this into third world countries where it's an even lower income population. And I think there's some other problems in some of those areas that are probably more urgent than type 2 diabetes. But I think type 2 diabetes in a more developed world is a really, top tier problem. But I think there are some parts of the world where diabetes is probably a second tier problem because there's some other, more life threatening problems that should be handled first.
I think bringing this back to tech, just so I can ask the
Yeah,
next question.
sure.
But I mean, obviously, the what you define as protocols that you defined, it allowed for you to be able to adhere to that and make it strict, so it's being followed. Obviously, that can be scaled using technology, but I mean, I'm assuming like once you started to see these results, your tech background was like, how do I sort of scale it using that side of things? What did you
Yeah,
try to
well, I'll
scale?
say this: we're heavy on the tech in the back end. Like, I don't want to give the impression we don't use technology. Like, 18 months ago, we had 13 different deployments of AI inside of our practice. I can't even tell you how many we have now,
Uh,
but we've got, right now, I'm telling my team, like, we have 225 different AI opportunities we've identified inside of our tiny little company to figure out how to get those 225 agents into an org chart with our existing team immediately. And so they're working to put 225 AI agents on our org chart right now. And how do you make that happen, very quickly? So, so we're very aggressive users of technology on the back end, but we don't let that get in the way of that human one-to-one interaction with our patient.
yeah, and that was the question that I wanted to ask. Was there a sort of learning that you had while sort of transitioning to scale when it came to the results that you were seeing using tech? Did you see anything that you felt like was scaled too fast that got broken up when you tried to apply this logic?
I mean, we're really careful about how we apply technology, right? So when we're applying technology to anything that's clinical or clinically tangential, we have
Mhm.
a much higher threshold for safety and security. And so, years ago, NASA created this kind of idea of manufacturing readiness levels for things that were going to go into space. And then that turned into technology readiness levels for things that were going to go into space. And then the National Institute of Health adopted a similar form of technology readiness levels for medical devices and things like that. And so, but there was nothing like that for medical practices. So we took that technology readiness levels for NIH and we then said, okay, how do you apply this to a medical practice? And anything that is kind of even touching something clinical, we have a much higher threshold for how quickly we can deploy it and how much testing it has to go through. It's just a much more rigorous process. But then where there's things that you can, like, meal planning is a much easier one because you make a meal plan for a patient and the provider's actually reading it before it goes out, so there's no, like, the patient doesn't get that meal plan without the provider stamping it and saying, yes, that's correct.
Interesting. Um, so I want to kind of shift focus to your previous experience. You've coached leaders in healthcare, the military, and billion organizations, and obviously that's added to your experience right now. But I'm sure this was what allowed you to build the foundation for the business at the moment. In your view, what leadership behaviors do you think directly influence clinical outcomes or systems performance? for the C-suite in these spaces?
Yeah, I think sometimes leaders forget that change management is change management. Whether you're changing an individual or an organization, people change for their own reasons. And the better that a leader can help people change for their own reasons, the more effective and the more quickly that change will take place. And so oftentimes I see leaders going through change because they see the change being good for the organization and for a number of people, but not maybe for all the stakeholders. And so helping each stakeholder understand why the change is good for them for their own reasons is a really important part of the process. And so when I was helping companies through change management, one of the steps we would go through is thinking about like how the change impacted each person and what would motivate that person to get aligned to the new goal, right? And so what we're doing here is very similar. We're taking someone and saying, hey, what's important to you in your health? And I'll give you another great example. We had a woman who came in and she was not clinically depressed, but she was not happy. She had retired. She didn't have a good reason to want to kind of live every day and wake up in the morning. And we asked what was important to her. And she wanted to teach underprivileged kids how to read, but didn't know how to do that. I said, no problem. Let's call your local library and see if the librarian will talk to us about that. We got on a three-way call with the librarian and had her set up for an appointment to go talk to the librarian about how to teach local underprivileged kids how to read. And all of a sudden, her outlook was so much more positive because she was living what she felt like her purpose was.
Hmm.
And so I think helping people, and again, I think this is management's job when they're going through change management is helping leaders of the organization get people aligned to the outcome and where the change is headed. And sometimes there are people who don't want to be on board when you change direction. That's okay, right?
Hmm.
But I do think helping people find their own reasons for being involved in the movement is an important part of change management.
Interesting. That almost seems like the philosophy that you've implemented in Persona, like you're kind of meeting people where they're at, not just the organization that you've built and the employees that you have, or even the patients, or even the kind of messaging that's going out to the rest of the partners that are coming on board. So you kind of operationalize that approach of building out the incentives for them and meeting them
Yeah.
exactly where they are and kind of building out. That
Well,
is
it's really high trust, right? So we made a change recently that we thought was a great change, and we pushed it out, and something went wrong, and people were like, "Hey, this isn't working." So we immediately rolled back the change because people felt like they could contact me directly in the organization and say, "Hey, this isn't working." And so as soon as I said, "Hey, it's not working," we started paying really close attention for 6 or 8 hours, and then we're like, "Okay, forget it, roll it back." We rolled it back. We came back together in a meeting and said, "Okay, tell me more. Why didn't this work?" And we walked through it. It's like, okay, here's how we're going to fix it. But that high trust environment, right? So when you get people involved in the process, like they were okay saying, "Hey, John, I think you made a mistake as the leader," and I'll own that. It's like, hey, we thought we were going the right direction. We went down that path. It was a mistake. We immediately got feedback. Roll it back. Go a different direction. It's so valuable to have that level of trust. And I mean, it gives me a high level of trust with my team that they'll give me feedback that's not just what I want to hear. It's sometimes it's the hard conversation too.
Yeah, I mean, trust is a very big component of adherence in general for chronic disease, and sort of helping people get through that. And you kind of really hit the nail on the head when you talked through in terms of that aspect. And it's very refreshing that you have this kind of a loop built in where you're able to get feedback directly from people. Um, and yeah, I think at the pace you're going, you probably want to scale that so that will become like the core sort of mantra for the business. So when it comes to like kind of going into the again uh, diving into the failures for health startups, and I want to sort of talk overarchingly because a lot of the listeners that we have will be healthcare startups owners that are running their organization and want to build that. So considering that you've advised hundreds of organizations with the responsibilities that you've had past, what are three most common failure modes you see, in health startups tracking chronic disease of today?
Yeah, I think one is underestimating the complexity of the system you're working within to be successful. So there's not just clinical outcomes, but there's also financial outcomes. Like I think you have to be able to have both. And I've seen a lot of digital health organizations that track KPIs to your point that may not be as clinically valid as most providers might want to see. And so that I think I'm sensitive to that in particular. I think that listening to the market, what the market wants, is a really important thing as well. Like how do you go out and listen to customers? And I can think of some great CEOs of companies you've never heard of and companies you have heard of that are super involved with the customer and get lots and lots and lots of feedback. And so we try to do a lot of that to hear like what is like. We had a new patient who came in Friday afternoon, and when I checked in the first thing this morning with our chief medical officer, it was like, hey, what was the feedback on that patient, our last patient on Friday? And the feedback was fantastic. But I'm always listening for like what are the things we can do better, right? So I want to hear good feedback so I can tell the team they did a great job. But I also want to hear that critical feedback to see if there's a lesson for us to learn. In some critical feedback, there is a lesson to learn. Some critical feedback, there's not. But I was talking to a company that I advised recently, and they wanted to ask about going this new direction. And I was like, well, do you have enough experience in that part of the market that you can talk definitively about what's going to happen, or do you need to interview more stakeholders? And what it came out to is they need more stakeholders. It's like, great. Who are the 10 different type of stakeholders that are impacted in that part of the market, and what 20 interviews do you need to go do to find out 20 interviews for each of those 10 types of, so it might be 200 interviews you've got to get done. And how many of do you have to go to 10, 20, 30 of them before you feel like you've got a direction? But in getting really smart interview questions, not just would you buy this product? Anybody can say, oh yeah, that's a great idea, I'll buy your product. And then of course it comes time to buy the product and no sales come through. So I think there's a little bit more sensitivity in our organization and the organizations that I guide, like, to not drink your own Kool-Aid.
I think you mentioned a really important point, which was that um, the way I would sort of see it, most businesses, they set up the right protocols, and then they have the right sort of thought process in terms of defining them. But then the adherence is where things start to fall apart. So that there's this protocol slash adherence loop that you've created in your organization, where you're not just getting a pulse check on the adherence, but you're also getting points that you can then iterate into the protocol to kind of keep on evolving it as it progresses. Do I understand that right?
Yeah, I mean, for us, phase one is assessment. So we're, for the first 30 days, we're making changes, but there's a massive amount of assessment happening during that first 30 days of the start protocol. Then we go into control mode, where how do you control the most important diseases? And that might take, another eight or 10 weeks in a lot of cases, sometimes more, but rarely. And then we get into sustainability. So then we try to stabilize the patient at that place. And then we start looking for opportunities to improve. And then it's like, okay, now how do we get people off of medications? How do we change lifestyle and exercise? That may have started during phase one, but in phase four, we're really starting to kind of optimize, like where is the patient comfortable with the lifestyle they want to have, so that we can then start finding ways off of the medication where that's appropriate. And then phase five is like long-term sustainability and monitoring.
So you mentioned at the start of when I asked this question, that founders consistently underestimate complexity. Could you expand on that a little bit more, especially like if you could give an example from your own experience where you thought that this was not going to be as difficult as it was, surprisingly, and how did you counter that?
Yeah, I mean, look, we knew how noisy the diabetes market was and is when we got into this market. We knew, like, I had studied it for years, as going through a doctoral program at a Research One university. Like, I really studied it. And then when we got into it, it was every bit as hard as I thought, times 10.
Mhm.
Like, it is just a very, very noisy market. And it's because it's a, $500 billion market that there's really sophisticated marketers marketing into. And it's just hard. And so we're up against that inside of our practice right now in terms of how we market into that world. And so I tell people too, and part of that is my own shortcomings in marketing. As good as I am at understanding diabetes and controlling diabetes, that's how bad I am at marketing to people who need help with diabetes. Like, so I've got this really big gap. And so now what I'm doing is saying, okay, well, who are the people like me that understand how to fix this marketing in this environment? And how do I get their help in the same way that patients get help from us? And so now we're navigating that part of the process. We finished our second clinical study. It was an observational study, this year. We're about to start publishing that. So now that we have kind of our second really important clinical set of observations, we feel like it's time to start the actual marketing of what we're doing. But that's going to require professional help.
Well, as a chief marketing officer for TechRevo, I think you're doing great with this interview. But
We've
yeah,
got work to do. We've got a lot of work to do.
yeah, and I think I mean your trials speak for themselves, right? Like 49 out of 50 patients. That's like exceptional beyond exceptional. Like there is nothing that replicates that currently. So I think you're kind of way ahead of the curve.
I mean,
Um,
here's a couple other ones, like things, just stories we don't get to tell very often. April of this year, a patient comes in, 28 years old, A1C 13.3%.
wow,
Her recent A1C as of the end of October, 6.2.
that's wow.
So we dropped 7.1% in 7 months, and
Wow,
then and off of insulin in
that's
seven
amazing.
months. So I mean, this is the kind of stuff, like, but we aren't getting these stories out there enough. Like, there's more to these stories that we've just got to be telling them more and more and more. So
Right.
that's the yeah
That's the marketing piece that you're missing. Um,
yeah.
well, as long as you have the sort of the results coming in, that marketing is just a vehicle to get things out there. So that's not going to be an issue
I'm
there.
as committed to learning about marketing as I was about learning about diabetes at this point. So I've got to go figure that out, and and I recognize that there's experts out there who can help me, and we're engaging those experts now in the same way that, I tell people all the time, for our patients, it's like it's a committed patient with an expert plan. And so we have committed we've patients that come to us that aren't committed, that we help them find the commitment, and then we provide the expert plan by finding out what they're actually going to do. Well, so now in this conversation around marketing, we're becoming the committed patient, right?
Yeah, that's flipping the tables a little
Yeah,
bit.
that's right.
Um, so I mean, bring this back to our audience. So let's say if TechRevel or any other technology partner wanted to build a scalable digital version of your protocol, what do you think must be included in version one? And like from your perspective, what should absolutely not be built yet? What are your
Yeah,
thoughts?
I think for us, we have some intellectual property that is probably really important to build into the system. But I mean, the system has to be set up for radical personalization, radical incrementalism, without a doubt. And it's got to be set up to make sure all the stakeholders are winning, not just the patient, not just the provider, but it has to be really set up thoughtfully across all of that. And we joke with people, like, people ask all the time, "What can you tell us how to do this?" It's like, well, it took us 10 years to figure it out, and our providers have to go through a year or more of training, much like a fellowship. It's like, just because you're exceptional at being a doctor and you know the biology of the brain doesn't naturally make you a neurosurgeon. Like, there's still a lot of work to be done to be a competent neurosurgeon. And that's what we're finding, is that we're taking all of our medical providers and teaching them all the things they have to know. Our mental health clinicians have to learn more about the medicines and how to work with the providers. And so we think we're finding a brand new subspecialty of medicine. Like, we don't think this is just like a set of technology. We think we found a brand new subspecialty of medicine.
Oh, interesting. I'd love to read the paper on that eventually when it's published.
Yeah.
Um, is it is are you are you, what steps are you at with the publishing aspect? This like is it something already published yet or
We're actually we this week we just finished all of our third party review, and in terms of internal third party review, so making sure editors go through it to make sure it's ready for sending off to journals. And now we've identified a journal, and so um, if any of your listeners know someone at the New England Journal of Medicine Catalyst, that's the place we're going to try to talk to first. Don't know if they'll be interested or not. We'll talk to people at the ADA and see if they're interested or not, but we're really hoping that someone will say, hey, your results are worthy of publishing. And we've got a really interesting paper that walks through not just what we did, but also what the barriers were, like what challenges we bumped into and what we think has to come next from a research perspective.
right. So I mean I want to kind of bring this push this forward a little bit into the future. Let's say fast forward to 2030. If you were designing the chronic disease system of the future from scratch, what foundation principle would you build on from your own experience?
Yeah, I think the first thing is treat it like, like infectious disease is different than primary care and endocrinology. And I think chronic metabolic disease that requires behavior change is kind of an implementation medicine problem. right? And so we think that this subspecialty of medicine will be about the implementation of medicines that does not take the place of endocrinology. I know a lot of endocrinologists and think the world of them. It won't take the place of cardiologists and primary care physicians. It won't take the place of the hospitals. This is about putting the glue into place and making sure that cross-functional implementation is working appropriately and for the long term. And that's how we're going to wring the cost out of care. That's how we're going to help people get healthy quickly and avoid amputations and blindness and all the problems that diabetes can cause. So I think what it's going to be is a much better medical outcome for patients, where they come in with a high level of expectation, and they get the outcomes they want very quickly from the doctors they want in a cost effective way. Like, I think that's going to happen, so that we can hopefully take type 2 diabetes off the map as a major problem. I don't know if that'll happen by 2030, but I think within the next 50 years, I think there's 1 billion people we can work through this problem in the next 50 years.
And considering all the sort of push towards AI, what role do you think AI would play in this event?
I mean, we've already got a roadmap that shows AI being something that helps the providers effectively. One crazy example, our providers get all the medical records that we can find on a patient, and we actually have AI go through all of them to highlight all of it, so that our providers can read a cohesive medical report before the patient comes in to visit number one. So that way they have kind of like the medical history isn't starting from zero, it's starting from all that data summarized down into the first visit. I think that's table stakes for the future. Like, that's going to happen. I think that we're going to work a lot of the administration through, automated processes to make administration much more easy. I think we're going to find a lot of medical problems a lot earlier on with AI. I think we're going to start to see things across systems where the AI is going to say, "Hey, have you considered this?" And the doctor can then actually consider things they hadn't considered before.
Interesting. And keeping that in mind and sort of understanding the flip side of it, what do you think from your perspective is the most overrated trend in digital health in this day and age?
I think people thinking that just because you have data, that people make decisions based on the data, or just an app can change someone's behavior. Like, we've tried that for 4 or 5 years, and some really smart people and a lot of money has been spent. And the truth is that I just heard about a report from one of our advisors, our medical advisors, that the incidence of diabetes is actually getting worse, not better. And so even with all these new drugs and new devices, I haven't seen the report firsthand yet, so I can't give you the exact numbers, but things are going the wrong direction. And I think that just because someone has, a digital device doesn't mean they're actually getting better. And just because they're engaging with it doesn't mean and just because they have it doesn't mean they're engaging with it. So I think there's still some more work to be done to kind of put it all together.
Interesting. Yeah, I would have never really considered that, especially with so many startups in that space, investing so much money. But yeah, I mean, if the data doesn't support it, we definitely have to have a
Well,
conversation
I
about
would I
that.
would tell anybody in the space to go look at Peterson Health Technology Institute and all of the research they've done about what the studies say about how people. It's not working yet. So
Interesting.
you have average A1Cs that are being driven down by 0.5 to 1.0% over a 12-month period. We have patients who are having a 1.7% decrease of A1C in 4 weeks.
Wow.
So three times in kind of the largest gap, 3 times the difference over 1 month instead of 12 months. And so what's that, 36 times more effective?
That is insane. Those numbers are just
Humans
wow.
matter.
Yeah, I after this interview, definitely am a believer of that.
Yeah.
Well, John, this conversation has given our audience an operational blueprint for chronic disease transformation, the systems, structures, behaviors, and design principles required to produce measurable, repeatable outcome that you have already shown. For everyone listening, especially healthcare CIOs, CTOs, CMOs, and COOs, and founders, you can learn more about John's work at percentahealth.com and johnoberg.com. And I'll tag that in the description of this video as well. And if you're building a next generation chronic care platform, workflow system, or digital health products, visit techrebel.com/health. We partner with leaders to turn proven models into scalable, intelligent platforms. John, thank you so much. This was exceptional. Thank you so much for going super detailed in your
Yeah.
approach. And yeah, I mean, this was amazing.
I look forward to staying in touch. Have me back anytime you have more questions. I love this and the opportunity to chat about it. And so thanks for having me. I'm really, really grateful to have had the opportunity.